I do.
Yeah.
All right, thank you. You're sworn in, and I'll turn it to the retreat to start their presentation.
All right, thank you very much. Let me just share the slides first. And go to presentation mode. All right, can you see that okay?
Yep, we see it, Steve.
All right, thank you very much. All right, I want to thank the Green Mountain Care Board for the opportunity to present our proposed budget for fiscal year and calendar year 2025 for the Brattleboro Retreat. And I'm on the wrong slide. There we go. In addition to our proposed budget, we'd like to provide a short summary of our work during 2024 and highlight the partnerships that we have built in our community and across the state. We'll also focus on the investments we've made to address challenges related to housing, transportation, and labor costs to reduce our dependence on contract labor. And finally, we'll provide a summary of our priorities as we look ahead for 2025. First, I'd like to just address kind of at a high level that while the retreat's down here in the bottom corner of the state, we really are a statewide resource for mental health services. And we receive inpatient admissions from the other 14 medical hospitals across the state and from around the region. We are the only Vermont provider for child and adolescent inpatient care. And we are one of the larger providers of outpatient counseling and partial hospitalization and intensive outpatient therapy delivered through telehealth, which allows us to reach across the state and the region. And finally, we have really worked closely over the last several years with DMH, DCF, and DVA to expand services as requested by the state to handle the inpatient demand and other levels of care. So with that, what I'd like to do is just turn it over to Dr. Jeffries, our Chief Medical Officer, and have him just review the items on the chart here, which really covers the array of services that we provide today. Dr. Jeffries.
Thank you, Steve. Good afternoon, everyone. And as Steve said, I am Dr. Carl Jeffries. I'm the Chief Medical Officer here at the retreat. And I'm going to be presenting just a very quick, brief overview of the services that we currently provide at the retreat and speak a little bit to some of our initiatives for the near future. I'm going to start with our inpatient services as it's a significant portion of the care that we provide and requires a large amount of our resources to provide that high acuity level of care. And so our inpatient services are provided in two separate buildings on our campus. One is the Tyler building, and that's where we provide our adult inpatient services. And then we have the Osgood building where we provide our children and adolescent services. The current list there shows Osgood 1, our children's unit, as being in the Osgood building. The Osgood 1 space is actually being currently under renovation, and so our children's unit is being provided currently on a separate part of our campus, but in the near future we'll be moving back into the Osgood building. So I'm going to review these very quickly. Tyler 1 and Tyler 2 are our general adult floors. Tyler 1 has a programming focus of LGBTQ to provide programming and safe space for our LGBTQ population, but provides services to the broad general public in need of acute psychiatric stabilization. Tyler 2 is our general floor. Each of those units have one has 19, 121, so we have a total of 40 beds for the general population. Tyler 3 and Tyler 4 are our adult intensive units. Those provide care for level 1 patients, forensic patients, and any of our higher acuity patients that require a little bit more intensive treatment. And then moving over to the Osgood building, we have one child unit, which has a bed capacity of 10 and provides services for actually as young as is needed. It's rare that we go below 6 up to around age 12, but the latency to teen transition, the patients will sometimes be on Osgood 1 and sometimes end up on the adolescent units. And then we have 2 adolescent units with 12 beds each. and they provide care up to the age of 17. Once somebody is 18, they will move over to our adult services. One important infrastructure aspect to all of our units is telehealth capacity. So every single one of our units has a telehealth dedicated room where that level of service that type of service can be provided at this level of care. We only have 2 units, the Tyler 1 and the Tyler 2 general adult units, that have providers who are primarily telehealth providers. The rest of the units, the telehealth services, provide us with flexibility, after hours access to providers when they might not otherwise or might otherwise have challenges with access to providers, as well as the ability to have family meetings and team meetings with people throughout the state. So increasing and improving our access to coordination of care in that way and having family members participate. I'm going to then move on to our residential services. Currently, we have 8 residential beds at our Abigail Rockwell Children's Center. Those are for children ages 6 to 12 primarily. However, some of our residential children will age and still require that level of care. And so we do expand up to at 14 years old at times, but we primarily accept patients through those ages. And then later in 2025, we do hope to reopen adolescent residential, this time at a PRTF level of care for adolescents ages 12, and again, primarily targeting up to 17, but as they age, we would continue to provide care as they transition into adult care. And then over to our outpatient services. I'm going to start with our outpatient psychotherapeutic and psychiatric clinic. It's called the Anna Marsh Clinic, and that provides the bulk of our outpatient services. Last year, we had around 30,000 visits in our Anna Marsh Clinic. There we provide individual, couples, family, group therapy, and then psychiatric services across the age range from children all the way to the geriatric population. And there also we have both telehealth capacity as well as in-person capacity, which does, again, expand our ability to service a broad range throughout the state and even other areas of the region. Then we have 4 shorter-term specialty clinical intervention clinics. I will start with we have 2 of them, the Transcranial Magnetic Stimulation Clinic and our Specialty Medication Clinic, which currently utilizes esketamine, that are both focused in and primary for treatment-resistant depression. They are, again, short-term intensive treatments. Transcranial magnetic stimulation is a daily service. Specialty medication is multiple times weekly for a set of times, usually several weeks, and then that service would end. So we accept referrals, again, from throughout the state and people who are in other service areas and have outpatient treatment providers otherwise, but come here for that specialty care. And then we have 2 partial hospital program, intensive outpatient program clinics that service it is a service that is provided for higher acuity patients who don't need an inpatient level of care. It is, again, short term, can be 4 or 6 weeks. Sometimes it expands beyond that. It is daily and intensive and multiple hours each day. It is primarily group therapy based. One of our clinics is, and all of these services are provided virtually via telehealth. And so again, it is a service that is available for the entire state as well as others in the general region. Our general clinic just services the general adult population, and then we have a specialty focused clinic that provides care for first responders and healthcare professionals. And with that, I'm going to turn it back over to Steve.
Thank you, Dr. Jeffries. So with that, I'd like to move on and talk about a few other things related to community partnerships. And there are several highlighted here that I just want to run through quickly. The first is a partnership we have with Brattleboro Memorial Hospital, where we have embedded clinicians in their primary care practices, their Four Seasons OBGYN, and the comprehensive HIV and AIDS clinic that they run. And these are clinicians that are on site in those locations, work in their electronic health records, and really allow a warm handoff between primary care and the mental health workers when a need arises that a patient needs additional services. And really, they focus on mental health screenings, some short-term therapy that may help them through whatever issue they're dealing with so that they don't need an additional referral elsewhere. And of course, then we obviously do work on referrals as well if the patient's condition warrants it. But that allows us to very quickly deliver some care kind of in the moment and then as needed. It allows us to provide that without having to set up new appointments and have the patient come back another time and so on. So it's really been a great model that I think works really well with our partner across town. We also provide pediatric psychiatry consultations. This one's done through telehealth for Rutland Regional Medical Center's ED. So we have a provider that specifically focuses on that as those needs arise. And then the HealthWorks Act is really a wonderful partnership that we have been working on for some time with Brattleboro Memorial again, also HCRS, our local designated agency, and Groundworks Collaborative. And this is really focused on the unhoused or the housing insecure population in the area. And what we do is we provide support and oversight for this organization, as well as mental health services as needed during the array of services that we try to bring to this population. And the Groundworks team really does an amazing job with outreach to this population. It's very challenging to find and then deliver care to these folks, but they really are the point person for that, and we complement that with our expertise in mental health. So it's a great partnership. And then we also have another partnership with SASH for All pilot program, and this is where, again, we have some embedded clinicians, and this really focuses on the population that's in affordable housing in the area. So again, someone on site, someone local that can be easily accessible to patients and folks in town. And then the last is really more of a forward-looking one, in that I think you're probably aware that Brattleboro Memorial Hospital is talking with the Community Health FQHC from Rutland about expanding into the Brattleboro region. And so we have been in discussions with Brattleboro Memorial and the Community Health FQHC teams over the last several months to look at how we can partner with them. They have a similar embedded mental health worker type model in their clinics as well. And we want to make sure that there's no gaps in service, and that perhaps we can work together to grow services in the area to meet the demand if needed. So this is really something that we're going to be monitoring through 2025. We don't know specifically the timing of this. There's some hurdles that the FQHC has to move through for approval. But as they do that, we'll be ready to work with them. And we visited them up in Rutland to get a better sense of the care they deliver. So I'm optimistic that that'll be something that'll be something we can participate in going forward. Other investments that we're making, and this is where I'm getting into the whole transportation and housing side of things. So the first one is an investment we made actually in 2023 to take a building in town, the Holden Home, which is owned by a senior living organization, and they had consolidated their operations into one building outside of this one. And so we decided to talk with them and end up leasing the property. We spent about $300,000 renovating it. And our goal was to have housing for travel staff, because as you know, we've got a lot of travelers. As many sites do, and we wanted to find a way to give them a place to stay locally without causing further compression on the local housing market, where it's challenging here like everywhere. So we, in addition to the initial renovations, we also spend about $577,000 a year on the lease. And as I mentioned, we initially built this in 2023, or we renovated it to really service the traveler staff. And as you'll see a little further down, we've been moving travel staff into core staff pretty significantly. And now with the rooms that are available, there's 35 rooms available. And now most of the staff that are there are now core staff that live further away from the retreat. And when they need to come in and work their 3 12-hour shifts, This gives them a safe, clean, close by place where they can stay. And we provide that to the core staff at either very reduced or even no rent when they initially come on board. And it allows us to remove that sort of housing challenge at the initial part of their employment. And I think it's really been a great benefit for our staff to be able to have that kind of a place available so close by and at such an affordable rate. Regarding transportation, we are continuing our contract with Rescue Inc. And our goal there, of course, was to really get after the ED wait times for patients that are waiting in EDs around the state. And so we have invested in this at a cost of $300,000 a year for the retreat. And then UVM also puts in an investment of $250,000. And so that covers the cost of the ambulance services that Rescue provides to go bring patients to us. And really, this has really had an impact, we think, on ED boarding times. But the other really key thing is that it gets the patient out of the ED and it gets them into treatment faster. And that's ultimately, I think, what everybody wants, right, is to get them into the right environment, get them to a place where they can get some help and really try to expedite that. And, sort of the operational back-end benefit for us is that it makes our admissions team much more efficient because now we have the ability to expedite that transportation, which can sometimes take 12 to 24 hours to get a patient over, if they're a long distance away. And I think it helps the local communities further afield from us because it's tough for them to have a truck from their small fleet be out of commission for them for 4, 5, 6 hours while they're transporting a patient to us. So we think this has been an important investment that we've made to contribute to the support of the statewide mission that we have. One thing I do want to point out is that this type of arrangement is made possible through a waiver through OneCare, and we're beginning some discussions about how we would continue this capability once OneCare stops their operations at the end of 2025. So that's on our radar to begin working on that now so that there isn't a gap. And so that's a couple of key investments I just wanted to touch on as we move forward. The next thing I wanted to touch on was workforce development. That top figure is really something we're really proud of, and I'll walk through this briefly. So when we met with the Green Mountain Care Board last year, you gave us a challenge or really a mission, if you will, to reduce our dependence on travel staff. And we really took that seriously and have invested a lot of time and energy in how to attack this problem. And we set what we thought was a pretty ambitious goal to drop our travel staff by 25%. And I think you can see from January to December, we've actually done that by more than 50%. And this is really a great collaboration between not only our HR staff and our recruiters, but our nursing leadership in particular, our nurse managers, and how we have been able to come together to more efficiently engage with candidates, talk with them about what the opportunities are. And you saw the array of things that we have that folks can participate in from different venues of care and so on. And that's a draw for people interested in working in mental health. And then it hasn't come from just offering really huge salaries. We think we're competitive, but we're certainly not, using dollars isn't what really draws people in for the most part. We think it's this mix of care, and then it's the type and the quality of the care that we deliver. And what we hear from some of these conversions are travelers who've worked with us, and then they said, wow, I really want to stay here and work with you because what I've seen in other health systems around the country don't compare to the quality and the depth of the care that you deliver here, and I want to be part of that. So that's really been a multifaceted success story for us, as you can see. And we expect this trend to continue. I don't know that we'll drop the other 50% in the next year, but we certainly expect this number to continue to come down as we move forward. And I think another piece of this is the second half of this slide, and that is related to education and development for our staff across the board. And so to touch on these briefly, the behavioral health technician training program, these are our frontline, sort of the mental health techs, if you will, that are with our patients 24/7. They're doing all the continuous visual observations and so on. And so we offer this training that's a multi-phase layered training that we build on in their time through the first year or two that they're here. And we can take someone off the street who's never done the job and train them enough to begin working, and then add layers of training for them so that they become more and more effective. And we've really found that to be a great recruiting tool for people that are entering the workforce in healthcare and looking for a way to start. Next one down, the RN residency program. This is where we're focusing on nurses coming out of nursing school. And so our director of clinical education has done a really wonderful job of building relationships with the nursing schools in the region, where we will go out and interact with those folks, identify nurses that have an interest in working in the mental health area, and then we'll pair that nurse with one of our more experienced nurses for a period of 6 months and offer them extensive training, not only when they first arrive through orientation, but also on the job training. So they're partnered with that person. They work the same shifts day after day, and they get on the spot training about how to do things, how to handle situations, how to de-escalate patients, and so on. And so that's an invaluable way. And I can tell you, as a nurse myself, coming out of school, you think you've learned a lot, and then you get into healthcare and you realize you really don't know that much about how to really deliver care. And I think this is a great bridge for nurses to take advantage of. So we started this program this year. We've got some folks in it now, and so far the feedback has been really great. The next level is really getting after operations and management training. So we have been utilizing a local expert who has been delivering training to our managers and directors, our middle management layer, to help those folks who may have been clinicians or clinical folks in a role that have been promoted up into a management role, and maybe have had little or no training on how to do budgets, how to manage staff, how to handle situations with your staff, and so on. So we are offering them training that has been really well attended, and we've gotten great feedback from them about the support this gives them to really understand the nuances of management. And we believe that this is going to help with our retention of staff over time. And then the last one, as I sort of move up the clinical chain here, is our psychology internship program, which we've been running since 2011. And this is a postdoctoral psychology internship that is accredited by the American Psychology Association. And it's a year-long full-time training experience, and it provides advanced doctoral candidates with the psychology training for completion of their degrees, and they need this for their licensing, this experience. And so the primary goal here really is to increase the number of psychologists providing services across the state of Vermont. And so for the 24-25 internship year, we have 8 trainees this year, and then we have 2 former interns who we've retained for postdoctoral fellowships. And they have the opportunity to have rotations in adolescent inpatient, which we're unique for, adult inpatient, and then the outpatient PHP-IOP programs that Dr. Jeffries just reviewed. And then they all also do a second rotation in the outpatient Anna Marsh Clinic to provide the counseling in the couples, families, and other family psychotherapy cases. And so we have been able to retain some of these folks. Over the years, 13 of the folks that have, of the 43 have completed it, 13 have continued to work at the retreat in some capacity. And today we have 6 of those folks currently on our staff. So it does help us to some degree, but we believe that it really does contribute to the state's need for these really highly specialized folks. So the last piece that I wanted to touch on before we get to the budget is just to focus on our, this Gantt chart sort of shows what we're going to focus on in 2025. And so the first line, the green line across the top there, is our medical record. We are replacing a very old electronic health record with Meditex EMR, and we are scheduled to go live with that in May of 2025. And this is going to be sort of a quantum leap for us to be able to really be able to give our clinicians a much more robust and modern electronic health record with voice recognition technology. It's going to have much stronger interoperability capabilities so that we can share records with the health systems and the providers that we share patients with. We'll be able to do that in a much more nimble way. And so the goal is to go live, as I said, in May, spend the summer and early fall stabilizing and then implementing a more robust business and clinical analytics tool set that comes with this application. So that's a huge focus for anybody who's done one of those before. You know, it's an all-encompassing effort. So that'll take a lot of our time and energy to do that. The next one is the new program that Dr. Jeffries mentioned, the adolescent PRTF that we would hope to open in the second half of the year. We are still waiting on some specifics around the bed licensing, and then we hope to begin contract talks with that very soon. The next two on the purple lines are really sort of those external impacts that are out there, and there's no surprises here, I think, either. We want to make sure that we're ready and able to plan and adapt related to the FQHC that potentially would come into town. And then we also want to participate in any type of statewide planning related to mental health services, related to the Act 167 recommendations. They called us out as to be a center of excellence in mental health. We believe we are that today, and we really want to help move forward with our partners at the state and with other providers to enhance services around the state as needed in a responsible way. And then the last three items down the bottom are really what I think of as the keep the lights on situation. It's everything every hospital does. It's reinforcing and improving always our quality and patient safety capabilities. We have a great new director of quality that I think is going to bring a whole new tool set to us that I think will be really fantastic, especially with new electronic health record. We're going to continue to enhance and build on our staff training and education because we know that pays off. And then the last one is really just the business of running a 100-bed psychiatric hospital and significant outpatient practices that our outpatient services see 30,000 patients a year. So we want to make sure that we run those as efficiently as possible and make sure we have the staffing to handle it. So with that, I'd like to turn it over to Jill Mischke, our CFO, to take you through the budget. Jill?
Thanks, Steve. Just a couple quick points before we start looking at some numbers. So a handful of really important assumptions went into this budget. So our largest contract for inpatient care is our APM contract, which we have with the state of Vermont for Medicaid patients. Well, that contract is still under negotiation, so we're assuming a $2,825 daily rate in the budget. Like I said, the contract is still under negotiation, so we think this is a conservative estimate of something that's achievable yet contains some risks, which we'll get to in a second. We're also assuming 4 to 5% merit increases for our staff this year. The union increases require negotiation, so that's why there's some variation there. We're planning on those to take effect July 1st. As Steve mentioned, we're looking at a Meditech go live of May 1st. We're not anticipating a reduction to our inpatient services, maybe a small reduction to outpatient services for a very brief moment, but there is huge potential for an impact to our accounts receivable with the Meditech go live and running two systems in tandem for some time. Finally, in the assumptions, our adolescent PRTF start date of July 1st with April 1 staffing starting expenses. So we're planning to start ramping up our expenses on April 1st with a go live date of July 1st to take our first patient for the adolescent PRTF, which is assumed in the budget. Of course, we're just starting the negotiation process with the state and rate setting, so the timing could move forward or move back from that assumption. A couple of risks to mention in our budget. Like I mentioned, the APM contracted daily rate is still being negotiated with the state. We'll have hopefully more information on that to come very soon. You'll see as we go through the budget that we do have declining days cash on hand. It's really for a couple of reasons. We receive a prospective payment each month and then a large reconciliation at the end of the year. So we're floating cash to the state in our prospective payments during the year and then catching it up in one fell swoop at the end. So that makes timing of payments very difficult. And also we have a lot of really necessary capital expenditures that we need to keep funding. As Steve mentioned, the FQHC is coming to Brattleboro. We really don't know what that impact will be, particularly in the Anna Marsh Clinic. Our age of plant, we have a very beautiful but very old and historic campus and buildings, and our patients can potentially be disruptive, and that's very costly to continually do the repairs and maintenance. There's a risk that the adolescent PRTF could be delayed. Reopening of that program, the timing would adjust both in revenue and expenses. So it's not a tremendous risk, but there could be some impact there. And finally, there could be a risk of a Meditech go live disruption. It's not anticipated, but would potentially be expensive. Talk about some numbers next. At a high level, this is our budget for 2025 that we're presenting to you today. So when we look at our net patient care revenue year over year, we're assuming $98 million in FY25 versus $93 million in FY24 for a $5 million change. What that really represents is about $4.9 million related to the adolescent PRTF that's not included in the 2024 budget, but is included in the 2025 budget. So when you take that out and normalize year over year, we're really looking at about a 1% net patient care revenue change year over year. So in total, other operating revenue changes are small. So our total operating revenue, we're looking to be close to that $1 million mark for total operating revenue in 2025 versus 2024 will probably be closer to 95 million. So again, that change really has mostly to do with the adolescent PRTF making the appearance in July. So a couple of important things to talk about in our expenses. This is really a great story that the retreat is happy to share when we talk about our traveler costs and our costs for employed staff. So our salaries and fringe for our employed staff are actually going up to $58 million in 2025 versus $47 million in 2024. So that's an increase of about $11 million. And that really represents not only the modest merit increases that we're incorporating in the budget, but really the transition of traveling staff to core staff. So we also see some of that same thing happening with the salaries and fringe and our providers. We're reducing reliance on locums thanks to all the work that Dr. Jeffries is doing and to hiring on physicians and other providers. So we're saving about $1 million in that. We're adding about $1 million in that category year over year, but having some offsetted savings in our locums expenses. We mentioned that offset in purchase services for travelers. So we're expecting a $10 million savings in what we're spending for the cost of travelers in 2025 versus 2024. So really showing signs of savings there. And then our other expenses, this really has to do with some, Meditech costs and just some inflationary expenses. So we have a modest $2 million increase year over year. So in total, our net operating income for 2025 is a break-even position of $633,000 with a very small operating margin. Steve?
Thanks, Jill. All right, so I think that's our presentation, and I want to thank the Green Mountain Care Board for the opportunity today to present our budget and our plans for 2025. Our focus is to continue to be a statewide resource for mental health services, and we look forward to collaborating with state agencies and other healthcare providers as we plan for the future of Vermont's healthcare needs. So with that, I'd like to close our presentation and turn things back over to Chair Foster and the board. So thank you very much.
Thank you all very much for your presentation. We'll have Matt Sutter provide a staff overview, and then we'll turn to board questions after Mr. Sutter. Thanks.
Thank you, Chair Foster. Let me share my screen. And is that looking full screen for everyone?
Yes.
Yes.
Great, thank you. So quick agenda for today's staff presentation. We'll start with a brief overview of the Green Mountain Care Board's hospital budget process and modifications made for the Brattleboro retreat. We'll then walk through standard benchmarks established by the board for FY25 budgets. We'll examine their submitted budget through this lens and provide an update on their finances. I'll briefly touch on a couple of specific items that were already covered during their presentation, their reduction in use of travelers and the adolescent psychiatric residential treatment facility. Finally, we'll give a staff recommendation at the end. I suspect we'll comment then. So just a quick recap. Annually, the board establishes hospital budget guidance, which includes benchmarks. The hospitals bear the burden of justifying their budgets, and failing that, the Green Mountain Care Board must adjust those budgets to align with state regulatory objectives. Here you'll find specific references to rule and statute. I won't belabor these, but they're available here for reference. So just for some quick history, Act 140 of 2020 extended our review to all hospitals not operated by the state. And the only one this really affected was Brattleboro Retreat. Last year was the first year that they were subject to a full budget review. And so this is obviously the second year. And however, despite this being a full budget review, there's several items in standard guidance that staff did not believe were necessarily relevant to the review, and those are outlined on the following slide. I apologize for the very small text, but I will go through this and kind of explain changes quickly from standard guidance. The benchmarks were unchanged, the same NPR, commercial growth, and operating margin benchmarks. The key difference is around the Section 2 comparative analytics. So this section was largely intended to, so if hospitals didn't meet the Section 1 benchmarks, this section was largely existed to kind of test hospitals' assertions that they're unable to comply with those established benchmarks. So, for example, if their commercial prices are much lower than other comparable hospitals, the hospital could argue to the board that they need to approve a commercial growth rate higher than guidance. Now, because of differences in Brattleboro Retreat's payer mix and just the services they offer, staff asked that if they request a commercial growth rate greater than 3.4%, to provide an internal comparison of public payer to commercial payer prices to allow us to provide a kind of a comparison of their prices. Should the retreat request an NPR increase greater than 3.5%, staff also requested comparisons to comparable psychiatric hospitals, but they did not, so they did not provide that. We also reduced a handful of reporting requirements, supplemental reporting requirements that we didn't think fit the retreat business model. So quickly, here's our benchmarks for net patient revenue and explanations. These are taken from our standard hospital budget slides. I won't again belabor these, and they're more reference material. So I just mentioned NPR, commercial growth, and operating margin in FY25 is how we're reestablished as benchmarks. So we established the NPR cap at 3.5% over the prior year budget in line with the Vermont All-Payer Model Agreement. For commercial rate growth, we looked at PCE price index plus 1%, which was 3.4% over fiscal year 25, and then operating margin greater than 0. And I may have actually, I don't think I may have put 1 in correctly on a previous slide, but those are the benchmarks. So just quickly looking at the retreat submission, for NPR, they submitted an increased budget to budget of 0.75%. And here you can see their 24 budget, their 24 projections, and 25 budget. On a percentage basis, this less than 1% increase is largely due to the projected revenue in 24 coming in significantly below budget. You might remember from the presentation you just heard that their projections are much lower. So if you look at their projected 24 to budgeted 25, it looks like a larger increase, but what we regulate on is budget to budget. But I'll discuss some of the differences from projection as well a little later. Commercial rate they submitted was a aggregate 6.7% increase, which exceeds guidance. The retreats argued that a commercial rate increase exceeding guidance is necessary to bring commercial prices in line with public payers. Unlike the other community hospitals, they're kind of in somewhat unique situation where commercial prices are in some cases lower than public players, and I think can theoretically result in a cost shift to public payers if they weren't aligned. Finally, their budgeted operating margin is over 0% at 0.65, which meets the benchmark from guidance. So diving right into their income statement, first looking at the revenue side, as previously mentioned, NPR is up less than 1% budget to budget. Reductions, and here's kind of a similar graph, but we've broken out kind of service areas. So you can see where these changes are from the prior year. And as like you said, very similar in dollar amounts to the prior year budget, but you can see a shift, a pretty large shift in revenue from inpatient budgeted to residential. And that kind of mirrors the reduction in inpatient if you look at their FY24 projections. Growth on the expense side is similarly low in total if you look budget to budget, but there's some large movements between lines. Most importantly, and as they mentioned in their presentation, they've had a lot of success in reducing traveler costs, which have allowed them to better allocate revenue towards permanent staff salaries. Yeah, that's a waterfall chart of their expense growth. Looking at, again, kind of looking back to revenue, if we consider it by payer, you can see a pretty significant drop from Medicaid due to decreased price and a drop in inpatient utilization. This is offset by increased prices in commercial, which we'll discuss a little bit later in more detail. And yeah. And then again, continuing with revenue, we're gonna look at payer mix here as well and rates. While they're still in negotiation, as I mentioned, their budget's assuming it 2008-25 per diem, Vermont Medicaid per diem, which is a cut, as you can see from the previous year. And I'd like to take just a minute to explain this chart you see on the right, because I think it's very useful, but maybe not the most immediately intuitive if you don't look at this stuff all the time. So this is basically taking the changes by payer from the last slide. Yeah, this one. And then showing the components of that change. So just to give you an example, so for Medicaid, they're expected to have a negative $2.4 million impact to the net payer revenue. What's driving this is $5 million down due to price, but offset somewhat by almost $1 million due to increased utilization, 1.3 due to payer mix, and a 0.3 due to all other. Because their FY24 projections are coming in below budget, we also wanted to provide a comparison of their FY24 performance relative to budget. While the dollar amounts are obviously different, it's a very similar story to what you saw before. Expense management, particularly amongst travelers, has allowed them to absorb the reduced revenue while enabling them to increase their spend on permanent staff. If you look at FY24 projected to FY25 budget, again, it's basically the same story. You're seeing cost reductions among travelers, allowing them to absorb cost increases among salaries, provider tax, others. So as mentioned, the only benchmark the retreat exceeded was its requested commercial increase. I just quoted this here, I won't read it, but from their budget narrative, the retreat noted that increasing commercial charges, essentially right-sizing them in relation to public payer rates, is important for addressing affordability. This is, I just wanted to stop there just for a second, because this is slightly different than the situation we see with other hospitals, namely that their per diem commercial prices are lower in some respects, or in many cases, than what Vermont Medicaid pays. So while the individual commercial rates are privileged, they have submitted to the board a table comparing Vermont Medicaid rates to specific commercial payers as evidence of that claim. And we can see where in some cases the public rates are significantly higher than what commercial insurers are paying. So in terms of considering this, to contextualize their commercial ask in terms of like affordability for the consumer, took a look at their budgeted commercial NPR of $15.4 million against the total commercial NPR in the among hospitals that are reviewed under this process. And they represent just under 1% of the total commercial net patient revenue in the system. I then took a look at what they submitted as a budget to budget increase and then compared that to what was approved system wide for the other hospitals. And it's similarly about 0.8, what they're requesting, despite being over the benchmark and guidance is almost identical 0.8% of the total increase FY24 to 25 approved for commercial NPR. Here's some financial margins. As you can see, they're budgeting a very conservative operating and total margin, largely due to that some uncertainty. It seems like with their public payer negotiation and budgeting conservative revenues accordingly. We'll just go through some quick financial ratios here. The retreats, age of plants, high. We see this. This is pretty common in New England, but just for information, their debt service coverage ratio is looking good. It's improved quite a bit since 23, but the flip side of that is their days cash on hand is quite a bit diminished. And there's a couple reasons there could be for that. Some of it is assuming additional accounts receivable, I think, due to the EMR system. So just on their balance sheet, there's a shift there. You can see it's some from cash to accounts receivable, which will affect the days cash. So they talked to this in their presentation, but for the 24 budget, the retreat ordered them to submit a plan to reduce traveler expense by 25%. They've hit this. They've hired a recruitment professional with experience working with external agencies. And they seem like they've had a lot of success reducing traveler costs. And like I mentioned, projection to budget is a additional 50% traveler labor expense. They also have the adolescent unit they describe. The program is a step down in acuity from inpatient care. So you saw that decrease in inpatient revenue and a kind of corresponding increase in residential. But this is also a great thing for Vermont because this kind of care has been having to go out of state. So I think we can actually pass it over to Mark now to kind of go through our standard budget conditions. And I can't see the presentation, so
yeah, I'm happy to do that, Matt.
Thank you.
So what I did is I just went ahead and put up all of our standard conditions from the hospital budget process that the board engaged with in August and September. I'm not going to read through all of the standard conditions, but I'll just explain a little bit about how we did this last year. So last year was the first year that the retreat was subject to full budget review. I wasn't here then, but looking back at the orders, it's clear that the setup was to impose the same conditions for the retreat as for the 14 community hospitals, but adjust a number of the dates to align with the retreat's calendar year, fiscal year. So what I've done here is identical to what we did last year. I went ahead and highlighted any dates that I changed from what were in the original standard conditions for the other hospitals. And yeah, Matt, you can go ahead and stay on this one for just a minute, but you'll see that like for the most part, reporting dates start on February or are tied to June or July. Again, by and large, these conditions match what the board did for FY24. There are one or two exceptions or changes or new items from last year, but comprehensively, the idea is the same set of conditions, but with dates that reflect the retreat's budget cycle. And you can go ahead to the next slide, Matt, and then the one after. I mean, if we need to reference these for any reason, that's fine. And Matt, do you want to just quickly walk through the staff recommendation, and then I can talk about the motion language?
Sure. So the staff recommendation is essentially to approve as submitted with an additional condition. So one, to approve NPR growth as submitted at 0.75 over the prior year's approved budget. It's also to approve commercial increase as submitted at 6.7% in aggregate over excuse me, 6.7% with the commercial rate increase for major payers approved at the amounts on their rate decomposition sheet. And then because they're kind of still in the negotiating process, an additional condition requiring the retreat to submit some financial tables updated after final negotiation with the state.
And if you hop to the last slide, I'll just speak to a minute as to template motion language here. I'll address a few things. So first, this is template motion language. What we've done, similar to the hospital process earlier this summer, is we've provided template motion language, but we're proposing is that the board discuss, get public comment today, do whatever it needs to do, but either hold off on a vote or table its vote until the 18th, which is next Wednesday. That would be the date for the board to vote on the retreat. Waiting gives time for additional public comment to come in. It gives the retreat a little bit of bandwidth to internalize anything here that might be new and respond to it if it chooses the need to. The second thing I'll point to is that the language at item 2 is language that would approve a change in charge and commercial rate at no more than 6.7 aggregate. And that would approve commercial rate increases for major payers at the amounts proposed in the hospital's rate decomposition sheet. Matt referenced this earlier, but those hospital-specific budgeted, or sorry, insurer payer-specific increases are confidential as trade secret, so we can't talk in public session about those specific items. But if the board has questions about the payer-specific commercial rate increases that the retreat is proposing, we have language available to go into executive session and speak with the retreat about those assumptions and proposals. And then the third item is subject to the standard conditions previously approved by the board with changes and additions as described today. Just to flesh out what that means the budget conditions that were on the prior slides with the changed dates that I showed highlighted, and with the additional item that Matt just described in the previous slide. So with that, I'll turn it back to you, Chair Foster, for I'm guessing for board questions.
Thank you all very much. We will turn to board questions. I know there will be an interest in an executive session on the issue that you flagged, Mark. So we'll start with any board questions, and then we'll see if there's a motion for executive session.
Okay, if you don't mind, I'll start. Is that all right, Chair Foster?
Thank you.
Good.
Thanks.
Okay. So thank you, Matt and Mark, actually, for helpful staff recommendations and analysis there. Appreciate it. And a huge thank you to the retreat for your presentation and for the important work that you do for all of Vermonters. We need the retreat to be strong, and I appreciate your efforts to stabilize the retreat over the last few years and, reduce the reliance on travelers and addressing housing and transportation. There's a lot of really great progress to see here. So I appreciate that. And I want to make sure we say that. I have a couple questions. Mostly I'm going to pull from the narrative. So I might reference something from the narrative, a page from the narrative. I wanted to ask you, I guess it was on page 2 of the narrative, if you could talk a little bit more about, under the projection for 24, you referenced the 4% below budget driven by occupancy rates lower than planned. And I just wanted to know if you could elaborate a little bit more on that, given we hear about so much high demand for mental health, capacity and inpatient beds. And what the planned occupancy rate was, and then what the actual occupancy rate was, and then how you're forecasting the occupancy rate for 25.
Thank you, and I'm going to ask Jill to take that question because it is something that we wrestle with on a regular basis about what to budget for average daily occupancy, and then can we really hit that, and how many of our 100 beds can we really have open and running every day? But Jill, can you pick up and respond, please?
Sure, I can respond. We always maintain the highest occupancy that we can for the state of Vermont. Dr. Jeffries can give more information about how the admission process works and the realities of turning over hospital beds at the retreat are not quite the same as they are in acute care hospitals. So that makes sometimes a difference in what occupancy rates are for us. The benchmark for occupancy rates is closer to 80 to 85%. Last year in our budget, we budgeted close to 95% occupancy rate. That's why we missed our target so substantially in our occupancy. This year, we're taking a far more conservative approach, and we're budgeting at just above 85% occupancy, which is targets that are much more achievable and align better with other hospitals in the nation.
Great, that's helpful. I appreciate that.
Yes.
Realistic is good, although it would be great if 95% could be hit. So, well,
It would be
actually,
great. I agree.
I mean, to some degree, if the need is there, right? If the need is there, it'd be better if there was not as much need in the state. But one of the next question I had was reference to the APM agreement, and I know you're working on that, and currently budgeting at 2825 with Medicaid. And you say here, as demonstrated by our budget numbers, this rate is not a truly sustainable rate and will create both significant deferred maintenance and a precarious cash position. Do you have an estimate of what the rate would be to be sustainable?
We believe the rate should be 2,900 to truly be sustainable and to get after those capital investments like fixing roofs and elevators and things like that, to be perfectly honest. You know, the rate we've been paid up through this year is 3,100, and we have, through working through managing our expenses and so on, we've tried to lower the sort of the unit cost of care, the daily rate for a patient, and we feel like we can be sustainable at 2,900, but we're not sure that we're going to get there, to be perfectly honest. So we had to pick a number that we thought was as low as we could potentially possibly somehow make do without doing a lot of those deferred maintenance issues. I think that's really how we picked that number, but we had to pick it a couple of weeks ago when the negotiations were still in the midst of discussion with the state.
Got it. And your calendar year starts soon, so those negotiations presumably have to be wrapped up soon.
That's what we're hoping.
Yeah. On page 7 of the narrative, it describes a Vermont Medicaid rate cut in 24. Sounds like you're getting another one in 25. It looks like there was a 4.8% rate cut in 24. Is that right? Or is that so?
Jill, can you respond to that?
The 3,100,
Sure.
I thought, okay. Yeah, just explain
Sure.
that.
It's a little bit of both. So the daily rate is 3,100 in 2024. However, the contract has these risk corridors built into them where we have periods where we're essentially providing for free care after we meet certain benchmarks. We have a ribbon of free care, then we go back to getting paid the $3,100. So the net effect is that reduced rate in 2024.
Okay, that makes sense to me. I was trying to reconcile that with the 3,100 that I'd seen for both 23 and 24. And what about the Medicare reduction in 2025? Can you speak a little bit about that? Looks like 2% reduction from Medicare.
That reduction, we can get back to you with a little more information. I think most of that is utilization, but I'd like to double check some numbers and then I can get back to you.
Okay, yeah, this was in the chart referencing the per diem rate. But
Okay,
is that- is
then
that
I'll want to double check that number and I can get back to you.
Okay, fantastic. And then on page 4, it talked about future planning and mentioned there was a bullet point, planning for reimbursement changes with the AHEAD model for fiscal year 26. And I'm just wondering, what are your anticipated reimbursement changes that are associated with the AHEAD model?
That's a great question. And to be perfectly honest, we're really not sure. You know, I listened to some presentations recently from AHS and the Green Mountain Care Board about the AHEAD model, and it seems as though there's a lot of uncertainty there, right? So how would we be reimbursed, for example, in 2026, if some hospitals are in the AHEAD model and some are not? And would they be in an APM, like, you know, part of an APM agreement with us or not? We just don't know the answer to that. And I'm sure state agencies don't know that yet as they're still negotiating. So really for us, this is in our radar starting January 1st to begin to watch that whole process very closely. And the request I made on the call the other day was to say, you know, as this becomes clearer, you know, we're ready to have conversations with you because we know we're different. And so how we're going to be reimbursed is going to be a different model than your typical medical-based hospital. And so we want to just make sure that we're available, but we're going to be looking at that very closely to try to understand that because frankly, we don't know yet.
Okay, yeah, helpful. I was just wondering if you had anticipated any direction even to
No.
reimbursement rates or anything.
No, my crystal ball is not working on that right now.
That's fair. That's very fair. I think that's true of a lot of entities. Okay, well, those are my questions. I thank you for your presentation and for answering them.
Thank you.
Hey, Dave Merman, I'll go next. Can I just sort of follow up on that? Can you explain to me how other hospitals potentially participating in a different payment model would affect your APM rate? Is your APM rate impacted by other hospitals in any way?
No, it's not affected by that.
Okay. It's set in a negotiation. Sorry, is it set in a negotiation with you and Medicaid? Is that the process that
With us and AHS?
you and AHS? Okay.
Yes.
So I have just a few questions. One other follow-up from a question that Member Holmes had, which is, and I'm sure I saw it in the narrative, but I'm just not seeing. I'm not finding it right now. But you said your occupancy rate budget was 95% for 24 and 85% for 25. What is your actual occupancy rate for 24?
Our actual occupancy rate is in the high 80s, so closer to 87.
Okay. And then one other question I have is, CDMC is planning to close their inpatient psychiatric unit. Do you have any thoughts on the projected impact of the closing of that facility on your census and your budget?
Yeah, you know, I think it's reasonable to expect that, you know, the adult inpatient census might go up by a few patients potentially, if those beds were to close. And, you know, there are many days that we might have a couple beds, but there's many days that we don't have any adult beds available. So, you know, some of the days that we have beds available, they're adolescent or children's beds. So of course, those patients wouldn't be able to take advantage of those. You know, but we're ready to continue to work with AHS to figure out how they can address that. But you know, as I look at our occupancy and as I look at our availability, I think we can, as I said, I think we can absorb a couple, but I don't think we could increase by 8 adult patients on a daily basis. I don't know what their their average daily occupancy is. I'm assuming it's 8 per day, but you know, that's our perspective at this point. It would maybe have a small increase, but difficult to predict at this point because I don't know where those patients come from or how acute they are.
One thing I noticed in the presentation, there was a slide where you show your expenses, and your provider tax looked like it was going up about 20%, but your net patient revenue, your total operating revenue looked like it was going up 5%. Could you give me some? I thought the provider tax was a 6% on NPR. I was just trying to figure out why there was such an increase in the provider tax this year.
Yeah, it had to do with how low it was at the beginning of the year, and then it changes mid-year. So when we increased in the middle of the year last year, we had a substantial increase mid-year based on our performance from the prior years that we weren't planning for. So we're doing better planning this year, is I guess the answer to that question.
Okay. So it's budget to budget. Yep. Okay.
Yes.
All right. That makes sense to me now. The rest of my questions are for the executive session. So thank you.
I'll go ahead and jump in. I also wanted to echo just thanks for all your work on the Travelers. That's really heartening and good to see your success. All of my questions are actually related to executive session and the commercial rate. So if others, I don't know when you want a motion on that, Chair Foster, but let me know. I'll make one whenever we're ready for it.
I have one question before we do that. So let me ask that. On the decline on the Medicaid payment, what's the rationale? What's your understanding of why?
I'm sorry, can you ask that again, please?
Your Medicaid reimbursement went down from 3,100 to 2,825 or so. Why is it declining?
It's declining. That'll be for 2025. And it would be declining because in the negotiations we're having with AHS, they asked us about, it's a mix of, you know, they buy 51 beds from us every day today in 2024 because they have sent us more patients than that typically over the last 2 years. We're looking at potentially providing somewhere around 57 or 59 beds, but they are looking for a lower rate for higher volume, essentially, is I think what that's part of what they're asking for. And as we look at what our expenses are and our total cost of care, as we get better reporting, and I have to, this is a compliment to my financial team at this point as they've become more established. We have our arms better around what our costs of care are. And as we have those discussions with AHS, we felt like we could come down on that cost a little bit to try to make the care more accessible, I guess, for the state. So it's really part of the negotiation process to try to figure out how we can serve more patients for them. I mean, I'd love to stay at 3,100. Sorry.
Well, so no, it makes sense to me. This may have been in a slide and I might have missed it, but how much you're trying to cost shift some of that reduced reimbursement onto commercial in this year's budget, correct?
Yes.
What's
and
the
that's an evolving
total
process.
What's the total dollar amount you're trying to shift onto commercial because of the lower Medicaid reimbursement?
I think we'll have to get back to you on that. I don't, Jill, unless you have that number, we can get you that number.
Okay. Just curious, and that's all I had. Thank you very much. Thank you, Robin.
Okay.
Sure. And I will just, one thing I just wanted to note in case it's helpful, on at least the Medicare ahead model, your type of hospital isn't eligible for a Medicare global budget. So should, at least for Medicare, wouldn't change your reimbursement rate. So I took a minute to look that up just in case that's helpful for your future thinking.
Thank you.
No problem. So I don't know if Mark has motion language he wants to throw up, but I think I have.
Yeah,
Oh,
I
great.
can
If you
do that,
that's great.
Robin, and I can explain just for the purpose of public knowledge, like what the executive session is, and I'll just get that.
Mark, why don't I do one other thing just so you can get the motion language together. I can take the healthcare advocate now in the public session. And then I think I will actually also take public comment now so that people don't have to wait for the executive session. So if you want to pull that together, I'll do that first. So why don't I turn to the healthcare advocate if they have any questions or comments?
Yeah, thank you, Chair Foster. Can you hear me okay?
Yes.
Okay, great. So I'll have a few questions and then I'll turn to Mike on our team. So just to start off, I had a follow-up question from the narrative. You wrote about your electronic medical record that it requires a lot of manual intervention for clean claims can leave, and you said you don't have the internal resources available to devote to collecting on claims that do not pay properly or promptly. Could you elaborate on that and what you mean by that?
Bill?
Sure. So our existing medical record, we've had since the late 90s, and it does take a lot of manual interventions to get a claim out the door. So all of our internal resources are really dedicated to that effect. So we lose the ability to do a lot of follow-up collection activity with individual patients and individual payers. We provide statements every month. We do a lot of work to try to get patients to pay. We don't send them to collections right away. We have a process for that in our financial aid policy, but we just don't have the internal bandwidth to do that final collection activity.
Okay. And are you hoping that will improve with the transition to? Yeah.
It absolutely will improve.
Okay. Thank you. I appreciate it.
You're welcome.
On a couple questions that come from the income statement and balance sheet, just for reference, I'm curious what is the main driver? It looks like to me, and I could be looking at the wrong thing, so please correct me. From looking at 23 to 25, there's a pretty substantial decrease in your cash and investments on the assets line. I wonder if you could explain what's driving that.
The decrease in cash really has to do with having a lot of deferred maintenance that we're trying to catch up on. For many, many years, we were unable to do that. And then the secondary part has to do with their increase in accounts receivable. So after we get through this budget presentation, that's the new focus for my office, is working on our days cash on hand.
Okay. And what just kind of drove the decision making between using cash relative to like issuing a bond or something like that for some of those capital investments?
We had a rough period of financial time post-COVID, and we had various banking agreements that we just were completed with. So we are in this kind of fresh period where we didn't have to take on more debt. We had resolved prior banking obligations. So we're kind of on the precipice of being able to do loans or debt or that kind of arrangement.
Got it. Okay. Just looking at your bad debt to free care, could you explain the variability between 23, 24, and 25? It seems like it's really whipsawed back and forth. And what's your level of confidence that like what you're projecting in 25 will really match what nets out in the actual?
Yeah, so the retreat has had some challenges in their financial team for a number of years. So I'm probably one of the longest tenured CFOs that we've had in quite some time. So I think what you're seeing is just different accounting practices throughout the last 3 years, having to do with different leadership at the top. So we've really been working hard on cleaning up some of our accounting assumptions. And that's, I think, some of the effect that you're seeing. So I do have a lot more confidence in what we're projecting for the future because we've really taken a hard look at what those assumptions are.
Okay, that's helpful. Thank you. And last question before I turn to Mike. I know you talked a little bit about using debt collectors, some of that related to the EMR and billing issues you discussed. I'm wondering how you ensure that the collectors that you use are also in compliance with Act 119 and the requirements around patient financial assistance and that sort of thing.
Interesting. I'll have to get in touch with my vice president of revenue cycle and we'll talk through that and we'll get back to you if that's okay.
Okay, well, thank you. And I'll turn to Mike.
Thank you, Sam. Thank you, Mr. Chair. Thank you, Brattleboro Retreat. I think it's important to just, before we ask tough questions, sometimes it's important to appreciate the good work that you do, really important work for our state. If you've listened to any other hospital budget hearing this year, you know that the HCA has this year been focusing on compliance with Act 119, the Patient Financial Assistance Law. And so with that in mind, I have just want to recognize where we see you at, and nothing I'm about to say, for everyone's information, we've attempted to communicate directly with you in advance of this hearing. There's nothing new here. So great job on a number of things, on a couple of things. Your plain language summary is really good and strong. Great job on translations, Spanish, French, Canadian, Tigrinya. I knew I'd blow that. Tigrinya, Pashto, and Dari. That does make you different from many other hospitals that haven't done that kind of translation work. And great job on your thresholds for income eligibility. You're more generous than the law requires. There's a number of areas where we think you're out of compliance with the law. And I'm just going to rattle through them quickly, and I'm not going to ask questions individually about them. We're concerned about your residency, your definition of income, the income documentation you're requiring, your requirements for both Medicaid and private insurance in order to be eligible, your definition of allowed assets, not covering deductibles and out-of-pocket expenses, which every other hospital has managed to figure out how to do, and some concerns about your definitions of medical necessity. So I just want to raise it here. Make sure. Well, I want to invite you to respond if you have anything you can say about a plan to come into compliance. Would appreciate that, or any response you have. I think my main job here today was to say, heads up, we're concerned about this, and we'll continue to focus on it.
Right, and well, I want to thank you for pointing those out, and really, we received your email, I think, just the other day, and I think Jill's team is already actually actively working on that and addressing everything that you brought up. So I think we made progress, as you pointed out, and I appreciate that. But we'll be bringing that into compliance, and we'll keep you posted on the progress. But we expect to do that pretty quickly.
Very good. Thank you. Thank you, Mr. Chair.
Thank you.
Great, thank you. Noticing a bit of a timing issue, I think we will have to go into executive session now, and then if there's public comment, we'll take it at the back end if there is any. So, Mr. Hanksler, why don't you go ahead with the motion language and can.
Yeah, we'll do. It should come up in a second. So just briefly, hospital budget hearings and meetings are open to the public. Under statute, there's an exception for various items that can be held in executive session, so not in the public. One of those is discussion of records that are exempt from copying and inspection by the public under the Public Records Act. One type of document that's exempt is trade secret documentation, and the retreat did submit, and the GMCB did grant trade secret exemption to payer-specific commercial prices, which is what we did with other hospitals that submitted that information this year. So, Member Lunge, this is motion language that addresses an executive session for that situation. I'll just say two quick things. The first is that I've included the Office of the Healthcare Advocate in here with the thinking that they are bound by the same confidentiality as the board under statute and provide testimony in this process. I also will point out that I didn't add the fact that that court reporter has been invited to this session, but for the sake of a transcript on our end, we would typically invite the court reporter in, and then that portion of the transcript would of course be exempt from public copying if somebody asked for that section.
Thank you. All right, I'll jump in. I move that we enter into an executive session to discuss records exempt from the access to public records provisions of 1 VSA section 316. The attendance at the executive session would include board members, staff, healthcare advocates office, as well as staff and representatives of the Brattleboro retreat. And the discussion of the exempt record shall not itself permit an extension of the executive session to the general subject. So we will limit our discussions to the confidential material.
I'll second.
All in favor, say aye.
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 Aye. The motion carries.
So I'll just say, in case it's helpful, that I think I just have like 2 or 3 questions. So I don't know about others, but I wouldn't expect that my questions would take more than a few minutes, certainly less than half an hour. In case you want to give a time approximation, Chair Foster.
My best sense is that would be plenty of time, and I think we probably all have the same types of questions if I'm reading the tea leaves.
Thank you.
Okay, so we will move to executive session with the court reporter, and why don't we take a quick 5-minute break so that people can transition over. We'll anticipate approximately 30 minutes or less in case people want to comment at the end. We'll have to do it that way. Great. We will take a break from here, and we'll be back at approximately around 3 o'clock. Thank you.
Are you guys sending me a link? I'm the court reporter, sorry. Are you sending me another link?
Oh, hi, Susanna. I'm sorry. I presumed you had it. We will do that.
Okay, thank you.
Are we getting a separate link as well? So I better reopen my email.
We will send that to the Brattleboro retreat folks as well.
Thank you.
All
right, so I gotta leave this, I assume.
Hey, if you guys could just give me 1 minute to bring my backup audio back into this one. Just give me a second.
Suzanne, just let us know when you're ready.
Yes, I'm just, give me 2 seconds. I just added my thing in and I'm just documenting that we are back in regular session.
Okay, so you're all set?
Okay, I'm good to go now. Yep, thank you.
Great. All right. No, thank you. We'll resume the hearing, and we thank everyone for their patience. I will open it to public comment. I did want to recognize that Representative Ann Donahue has attended today. Thank you, Representative, for being here and for your role in advocacy and mental health. I just wanted to recognize your participation today. If there's any public comment, please use raise a hand and I will call on folks. Representative Donahue.
Thank you. Thank you very much. I did want to make a couple of comments. And first of all, to really thank the retreat for its leadership in avoiding the use of offensive and hurtful language that's sometimes comes up. And that's the term behavioral health, which is, stigmatizing and hurtful to many of us with mental health conditions. I did notice in the PowerPoint that there is just one small area where it is in use at the retreat. And so I hope that they will look at that staff title to make that change as well. I wanted to talk about the increase in the commercial rates in the budget. And I want to say I so very strongly support the retreat presentation on that proposal. I think many people are aware that the underpayment by commercial insurance generally in terms of all areas of mental health, it impairs access, actually creates denial of care in some cases, certainly denies parity. And it's across the healthcare spectrum. So the move in this case is a very positive one and hopefully will be part of an ongoing one. It also has a real effect in terms of that transfer, the fact that the state ends up subsidizing care for commercial insurance. And even in terms of the retreats building, sustain its own stability, the state having to make major investments, which really, just to note, really creates some risks to the state because of its over-reliance really on a type of care that's often recognized as not being the best type. The strong federal policies opposing the use of non-integrated freestanding psychiatric care through both its Medicare restrictions on payments and the IMD restrictions on payments. So it is a high-risk area, and the more that we can move towards parity and reimbursement, the better. And the third thing I wanted to say is just a appreciation that the retreat did finally resolve the questions about the the psychiatric residential treatment facility in terms of locked and involuntary care. It was a long time coming. I think the time it took could have saved the retreat money and the Green Mountain Care Board money, and avoid delay if the retreat had been responsive on that whole issue faster. But it is now on the record, thanks to the Green Mountain Care Board's pressing the issue that it is not a locked or involuntary facility, and I appreciate that the retreat resolved that issue. Thank you.
Thank you, Representative Donahue, for your comments and for participation. Any other public comment today? Great. Dr. Jeffries, Ms. Metschke, and Mr. Cummings, thank you very much for the presentation, and to our staff for working with you and your work with them and providing this presentation today, and for the information in the executive session, which was very helpful. Seeing no other public comment, is there a motion to adjourn?
So moved.
Second?
All in favor, say aye.
Aye.
Aye. The motion's approved. I hope everyone has a really wonderful weekend, and thank you for attending today. We are
Thank you
adjourned.
very- Appreciate it.
Thank you.
Thank you.
Have a good weekend.